Now we'll go for the second session, and here I'm going to present Dr. Tariq Al-Musawi. Tariq Al-Musawi, he's our ex-resident in Bahrain, but now he works in Saad Hospital, and he holds many responsibilities. I will mention some of them only. One of them is he is the Infection Control Directorate of the Saad Hospital. He's also a consultant infectious diseases. He's responsible for the ICU care, critical care, and he's also a lecturer in the RCSI University and some more. So I think Tariq will give us a talk today about how you manage your time. Please.
Thank you, Dr. Huda. It's so nice to be introduced by you personally. Backward, forward, okay. Okay, it's a great pleasure to be standing in a podium in Bahrain. I'm a Bahraini physician, as Dr. Huda said, and I practice in Saudi Arabia. So this is a hometown boy presenting at home. My talk is going to be about how to optimize antibiotic stewardship in the ICU, and for which I would enumerate some of what had been mentioned earlier this morning. There are a few interesting issues, or I would call important facts, that needs to be known before I start my talk. Fact number one, the escape pathogens. This happened to be the first slide being introduced to you this early morning in the very first talk, and it has been shown to you many times, and I cannot promise that it's going to be the last time this slide is going to be shown to you. There is more to come about it. So this represents the resistant pathogens that are frequently encountered in nosocomial settings and mainly in ICU. Enterococcus, Faecium or VRE, MRSA, Staph aureus, Clip pneumo, and E. coli, ESBL producers, MDR, Abomani, and Pseudomonas aeruginosa, as well as Enterobacter species, and you may add C. diff to that too. Fact number two, mortality associated with initial inadequate antibiotic therapy among ICU patients with serious infections shown significance far more than that when appropriate antibiotic were started to do so. This has been shown over the years with different studies, different places, different timings, different designs, and so on. These two facts together, that we have a lot of multi-drug resistance and not adequately treating in the beginning, brought antibiotic consumption to a lot of trouble. But these are facts, and we have to deal with it. That led to a report in the Archives of Internal Medicine in 2003, which says as much as 30 to 50% of antibiotic use in hospital is taking place in ICUs, and 30 to 50% again of that is inappropriate use. So this brings about what we could do further. So we do have two facts that we have to deal with: high resistance and high mortality with inadequate treatment. So there we go. We go very broad. And then where do we go from there? The remaining of this talk will be talking about interventions and outcomes. General policies and intervention related to antibiotic stewardship, whether it's in the ICU or any hospital, may be looked into many different ways. Those that support optimal antibiotic use, like dose documentation, indication, contraindication, duration, you name it, or develop and implement facility-specific treatment recommendations. The CDC also looked at it by categorizing them into these three broad interventions: as broad as antibiotic timeout or prior authorization, or pharmacy-driven interventions by changing from IV to oral, or deadlines that they would stop, or infection and syndrome-specific interventions. My talk is going to be about the interventions that has been studied most in the ICU, not in a general hospital setting. These are the different antibiotic stewardship interventions that had been looked into, and I'm correlating them with certain outcomes related to their impact. We start with the antibiotic restriction or pre-approval, maybe with just one line or a few words about each of these lines for some of those who are not familiar with it. The antibiotic restriction or pre-approval would basically mean that before any certain group of antibiotics being prescribed, somebody who is authorized to do so would give the approval to it. These antibiotics are part of the hospital formulary, but you as a physician cannot prescribe them unless you are of certain category, like being infectious disease or approval that comes from pharmacy or an intensivist or hematology oncology as specified per hospital policy. The second intervention is formal infectious disease physician consultation. Some which says, okay, then we have this group of antibiotics. We can only prescribe it, not only with approval. The moment you prescribe it, you call the infectious disease doctor, and then he takes the care hand in hand with the primary physician. A third intervention is implementation of guidelines or protocol for de-escalation, whereby you would say, okay, for something like ventilator-associated pneumonia, if you get this organism and it is sensitive to that, you de-escalate from this broad spectrum to third-generation cephalosporin, or to quinolones, or to aminoglycosides combined with something. So this is whatever you design based on the targets you want to achieve. Formal reassessment of antibiotics of a pre-specified day of therapy. Some would say, okay, for those categories of antibiotics, once they are being prescribed, you are welcome to do so in the first 1 or 2 or 3 days. By day 3, then a team would come and evaluate, should we go further with this or not? And they may come on day 3, day 7, day 10, day 12, 14, or any combination of those, depending on what is the design is. But this is one of the modalities of that. Another is guidelines for antibiotic prophylaxis and treatment in the ICU, whereby the ICU would put its own protocol for prophylaxis for certain diseases or certain surgeries and the treatments accordingly based on their local data. The last but not the least is implementation of computer-assisted decision support, whereby in a computer setting or a program, whenever a pathogen is brought about with certain antibiogram, the computer will help you choose which antibiotic to go for. And here are the outcomes of some of those listed interventions. A lot of times, it might not be one intervention, it could be a combination as well. What about the amount of targeted or overall antibiotic use? These are several studies which have looked into different units of measurement, and for most of which, if not all, actually have shown a significant reduction in the amount of antibiotic, whichever unit they have used. The abbreviation of DDD stands for defined daily dose, or DOT as in duration of therapy. Although they are so heterogeneous, yes, you cannot compare, but for every study per se, you could see a significant difference in the majority of them, and there are even more. Some did not attain that significant difference depending on the design of that study. But whether it's a daily defined dose or a duration of therapy, following antibiotic stewardship would lead to reduction. But guess what? Most studies of restriction reported significant reduction in the use of targeted antibiotics have somehow showed compensatory increase by almost 200 to 300% in the use of other agents with almost similar spectrum of use. So what are we dealing with? We are squeezing the balloon. Yes, I'm trying to restrict carbapenems, but more piperacillin tazobactam is being used, or cefepime at the expense is being used. So this is something that you need to look into, which is likely to happen. Here are more evidences for squeezing the balloon phenomena. There are some studies of fluoroquinolone restriction that resulted in an increased use of cefepime in one study, or aminoglycoside/macrolides combination. Other studies led to increased piptazo use when restricting for ceftazidime to avoid ESBL, for example, in ICUs, or cefepime as a broad spectrum. What about appropriateness of antibiotic? This is another outcome that happened to occur after some of these restrictions. This was fairly good and very positive outcome. There were fewer susceptible mismatch alerts when there are management support programs through the computer were shown, 12 versus 103 cases per year in this study. Excessive drug dosage alerts were 87 versus 2002. These are comparing different times when the computer system for stewardship is used or when it is left for the physician to decide by their own. And the mean days of excessive anti-infective doses in comparison, 2.7 versus 5.9 days with significant difference. Duration of therapy as the next outcome. The introduction of formal feedback on day 14 resulted in doctors discontinuing antibiotic therapy in 90% as compared with 48% of patients without such feedback. Wonderful outcome and with a great significance. And a formal daily guideline for reassessment of VAP treatment led to a shorter duration of treatment in this chest study. Re-evaluation guidelines, which I mentioned either on day 3, day 7, day 10, or several of these days, at this time at day 3 for patients with pulmonary infiltrate, led to far fewer patients being treated beyond this time point, 28% versus 93%, whereby when you help by re-evaluating on day 3, you have made a 28% of consumption compared to 93 if where the doctors were just to continue by their own targeting a pulmonary infiltrate, which could be anything, not necessarily pneumonia. Much shorter mean duration of an antibiotic treatment of 3 versus 9.8 days. Broad day 3 reassessment protocol for all antibiotic recipients reduced average treatment duration in ICU from 14 plus minus 2.9 days to 11.9 days. Before I speak about resistant, I would like to give some points about maybe antibiotic cost. This was actually an issue because units of cost reporting varied from one place to the other, from one design of a study to the other. And the comparative data overall, that is whatever shown, no matter how the strength or the strength of that study showed some reduced cost. There were no studies that recommended or summarized the impact of cost saved related to minimization of antibiotic adverse events as far as I have searched, or selection of resistant agents. We know that we reduce the resistance, as I'm going to show a lot of slides now, but none of the studies have shown what is the impact dollar-wise, dinar-wise, dirham-wise in reduction the cost as by reducing the rate of resistance. In fact, one study said there could be more cost that came about from consulting infectious diseases, and I don't think that's a caveat. I think that's a great outcome. Next outcome is rate of antibiotic resistance, and this is one of the main reasons why antibiotic stewardship even were brought about. Yes, we've got a lot of other good outcomes that I have just illustrated, but this was the main reason why antibiotic stewardship and why conferences and workshops like this are being carried out. Here are some evidences. Do they work? Let's see. Ceftazidime restriction led to a reduced ceftazidime resistant Abomani and ESBL producing pneumonia in one study, led to reduced ceftazidime resistant Pseudomonas aeruginosa in those two studies, or E. coli and Clipneumo. A day 3 reassessment protocol performed over 2 years in one study was associated with reduction in ESBL producing Klebsiella and carbapenem resistant Pseudomonas with the numbers shown. A day 3, day 7, and day 10 antibiotic reassessment intervention performed over 3 years demonstrated reduction in antibiotic-resistant bacteria of nosocomial infections in general, MRSA, and ceftriaxone-resistant Enterobacteriaceae, but showed no impact on ceftazidime-resistant Pseudomonas or ESBL-producing Enterobacteriaceae. So depending how the design is, depending on what the goal is, you may get different outcomes. There are some unanticipated beneficial effects induced at an observed reduction in MRSA with ciprofloxacin restriction. They were restricting ciprofloxacin for some reason, yet that reduced MRSA, thanks God. But that was an unanticipated beneficial effect. But we know the use of antibiotics in general increases the risk of MRSA variably without further specification. Piptazo and imipenem-resistant Pseudomonas aeruginosa with ceftazidime restriction. And unanticipated negative effects included an increase in penicillinase-producing clipneumo with ceftazidime restriction, favoring the use of piptazo. Here are some clinical outcomes that we would wish to have more data, more information about to consolidate our administration in hospitals and increase the awareness with more evidences that we could bring about more clinical outcome. Yet, there are no studies which solidly show that nosocomial infection rates in general can be reduced. Some touched upon it, as a secondary outcome, but no particular study designed to show so with a great evidence. Length of stay, either in ICU or in hospital, was not looked into carefully to come up with a strong conclusion as well. Likewise, mortality have not shown so well. Now, with that, I would like to discuss in the coming few minutes or so our model of antibiotic stewardship in our ICU. These are two photos of the hospital where I practiced in the Khobar in the Eastern Province in Saudi Arabia. This is a tertiary hospital, and our ICU is composed of around, we have a capacity of 84 beds between ICU and intermediate care, and the ICU level are around 45 patients on the average, or designated over 2 units, medical and surgical. And our model or antibiotic stewardship practice program in our ICU depend on these 4 people or the 4 pillars that bring about a successful stewardship program that we have it. In a nutshell, how we practice is a combination of what you have seen of different interventions put together. The team is composed of a physician, a pharmacist, a microbiologist, and an infection control officer. The practice in our unit depends on 5 intensivists, one of which happened to be an infectious disease doctor as well, who is myself. I do have a clinical pharmacist who happen also to be one of the audience sitting with you now, a microbiologist, an infectious disease, an infection control officer. We sit in the morning report at 8 o'clock and we discuss all the cases with their data, microdata, lab data, and everything. So an infectious disease doctor, pharmacist, and microbiologist with the infection control are listening to all this data. The microbiologists bring every morning results fresh from the oven, from the microbiology, and then update the group with what the data are. Then we do of course, the infectious disease together with the pharmacist, listening to the story, deciding upon what to do with the ongoing antibiotics or starting or de-escalating. We usually do another round after the bedside round to the microbiology lab by the infectious disease and the pharmacist, looking for results that are pending to come or expected to come by the afternoon, and further de-escalation of possible upgrade or changes accordingly. That second round will not only change the type of antibiotic, but may change the doses depending on further results that may come about creatinine or about further intervention taking to patients by dialysis or what have you. And that cycle repeats itself again and again. The infection control officer makes a fairly specific audit about VAB or blood-stimulated infection because she is within the team where the infectious disease doctor put the match together for a line sepsis or a VAB or ruling in or ruling out these diseases. So this is how we have been doing it, following some of those interventions that I have shown you, not necessarily defining which one, but it's a mix that is all put together. My conclusion to this talk is going to be about giving some tips about how I think antibiotic stewardship could be conducted in your ICUs or in your units. First of all, you have to know the local data. And local data is not only the antibiogram that you have in the hospital, but you need to know where your consumptions are, your resistant rates, and then whereby you could, after knowing all what you have, you need to define your target. And from the data, you would say, okay, we're using a lot of carbapenems, then my target would be reduction in carbapenems, and maybe I want that to be at the expense of something. So it could be one target, it could be more than target. It could be an inpatient, it could be an outpatient, or both together, like those who want to save more quinolones, oral administration of quinolones in outpatient to prevent E. coli being resistant to quinolones, for example. So after defining targets, you pick a strategy. You say, okay, I either want to have a group, I would call stewardship program, clinical pharmacist from the ICU, if it's an ICU program, with an ID doctor, with a chief intensivist maybe, with infection control, and so on, even some infection control champions or pioneers, if you will, whichever you name them. But this is how you pick the strategy that you think it would suit. You formulate a team, as I said, and then you audit outcome. And take a period of time to say 3 months, 6 months, and so on. And then this is how you would audit and then redesign. You would say, no, we're not doing well because we get a leak here, or this is not working that way, or maybe I need a stronger empowerment, say, from the administration, and so on and so forth. And I think the coming workshops in the coming 2 days will talk a lot about this. That brings me to the end of my presentation, and I will be very happy to entertain any of your questions in the discussion session. Thank you very much.